Onc Live Insights is a video editorial program produced by Onc Live.
In other hematologic malignancies like non-Hodgkin's lymphoma, maintenance therapy has an active role. Are there any agents being evaluated, or do you use any maintenance therapy in multiple myeloma?
Yes, so maintenance is a big thing in myeloma, right? So I talked a little bit about it in the transplant ineligible patients. I don't like to use the word maintenance because the way you think about maintenance is you start with something and then you maintain on something. The way we are doing our non-transplant eligible studies is we are essentially promoting or suggesting that you should be continued on therapy based on whatever trials we have out there. And overwhelmingly, all of those trials have shown staying on treatment is what's going to keep your remission more durable. It's going to increase the depth of the remission, and it's going to increase the durability of that remission as well. And, the concern with that has been you might try and develop resistance if you keep people on treatment too long. And the EMEA has actually tried to address this. And at this meeting, Dr. Palumbo will be presenting later on, where we've looked at PFS2. PFS2 is progression-free survival, the second progression-free survival. So not the first one with this line of treatment, but if this line of treatment is going to increase resistance to your follow-up drugs, you may not want to continue it, and therefore we've looked at PFS2. But the ones who have a higher PFS1 will also have a higher PFS2, suggesting that we are not really promoting a resistant clone here. So I think it's safe to say that we'd all like to continue with treatment if you can. In the transplant-eligible patients, I think the maintenance piece is a lot clearer. There's, at least 3 different studies or 4 different studies which have looked at different maintenance agents. Through the CLGB study in the US, we've looked at lenalidomide maintenance post-transplant, where patients were randomized to receiving lenalidomide versus no lenalidomide maintenance. The French have looked at it in a very similar fashion, again, placebo versus lenalidomide, and both of those studies showed a doubling of progression-free survival when you were on maintenance with lenalidomide. There is a slight word of caution here, and what we have seen in patients who've stayed on maintenance is the risk of second cancers. There has been a risk of secondary hematologic cancers, and that risk is about, depending on which study you look at, is about 2 or 3%. Having said that, when you balance out the risk of progression to the risk of the second cancer, I think overwhelmingly all of us would argue that patients should stay on maintenance. What we don't know as yet is how long is maintenance good. Do we do a year of maintenance? Do we do 2 years of maintenance? Do we do indefinite maintenance? The way the studies have been designed, when we did the CLGB study, it was indefinite maintenance. And most of us, at least I, in my practice, use indefinite maintenance. But I think this is an important question that we need to address as a research community. And we're beginning to do that. We're beginning to look at minimal residual disease status, MRD status. We can do it genotypically now, and we can do it by immunophenotyping as well. So there's 2 different techniques of looking at that. And if you look at MRD at different stages, can we identify a certain subset of patients who achieve that MRD status? And then we can say, after this, it's okay for you not to be on treatment, because there's a lot of unseen myeloma, which is kind of under the tip of the iceberg. What you're treating initially is that tip, and then you want to get rid of everything which is below the surface. And by continuing treatment, I think that's exactly what we're doing, which is how we're deepening the remissions. I talked about lenalidomide. So lenalidomide is kind of accepted as maintenance treatment. There are studies with bortezomib as well, and different studies have shown if you use, they're not necessarily great maintenance studies because, the induction part was a little bit different, but if you look at the HO1 data, when you use bortezomib subcutaneously every other week, there was a PFS benefit as well as a survival benefit in that group of patients. And we could only start thinking of proteasome inhibitors as maintenance when we switched to using bortezomib subcutaneously, because we decreased the risk of neuropathy, and by doing so, patients could stay on this drug for a protracted period of time. As far as the future, I think it's really great because we have newer oral proteasome inhibitors. You have the Millennium compound MLN9708, also called ixazomib, and we're already doing clinical trials with those drugs as we speak. We're using them in induction, but this is convenient. This drug has a very long half-life. We use it once a week, and it would be a perfect maintenance drug. And those trials are just about, some of them have actually started and others soon to follow. So in addition to lenalidomide, I do think we'll have other drugs as well.
So in some hematologic malignancies, like non-Hodgkin's lymphoma, for instance, maintenance therapy plays a role. Mm-hmm. What role does it play in multiple myeloma, and how do you incorporate it in practice?
I think maintenance is an important part of the treatment paradigm now, especially in the context of post-transplant maintenance. And what we do at our center is actually use a risk-adapted maintenance, and that is for standard risk patients who are post-transplant, we would give them single-agent lenalidomide. For patients who are high risk, as I mentioned earlier, we would use that RVD triplet combination because one drug is probably not sufficient. And for patients with 414 translocation or who appear to be relatively IMiD insensitive, those patients we would use a bortezomib-based maintenance approach on once a week subcutaneous dosing as well. So we use this risk piece to inform how we manage maintenance in the post-transplant setting. In older patients, you can apply the same sorts of rules. The difference is there's no transplant. And so you look at patients, you give them a well-tolerated, less intensive induction, and then again, think about maintenance based on risk.
And can you elaborate a little more specifically on the role of the nurse in monitoring disease progression and toxicity in the clinical management?
Sure. So the nurse practitioners see patients autonomously, so we are doing the whole management, telling the patients about the drug. Well, we do disease education also, but telling the patient about the drug and reporting to them what we are looking for as far as toxicities. The clinicians also will help educate the patients if a physician decides that pomalidomide is the drug of choice to treat their disease. The clinician will go over the dosing schedule. That's really important too, the dosing schedule, how to take the drug, when to go for labs, that kind of thing. And then talking about the adverse events that could be experienced, and then telling the patients when to call us. And then, of course, we have the nurse navigators who are instrumental in getting that initial contact with the patient. They may call and say, I just started my pomalidomide 2 weeks ago, and I'm experiencing XYZ, whatever it may be, and the nurse navigator is frequently the first nurse who is in contact with them to help manage that side effect. And again, we have infusion room nurses that may be administering zoledronate, hydration, transfusions, a variety of other agents for myeloma, supportive care, and treatments. Those nurses are also very familiar with pomalidomide. Those patients may also be on oral oncolytics, and they can also help manage the side effects if the patient communicates with them about what they're experiencing. So all of our nurses are pretty well educated about the drugs used to treat myeloma, what are the potential side effects, and how to manage them appropriately.